I'm Corey Slovis. I direct emergency medicine at Vanderbilt Medical Center. I serve as professor and chair of the Department of Emergency Medicine. My role in EMS is I direct from the medical point Nashville Fire Department and have the privilege of being their medical director and also being the medical director at the Nashville International Airport. At EMS today I spoke about the diagnosis and treatment of acute myocardial infarction, and unfortunately AJ forced me into giving it twice, but I believe the reason I did have to give it twice was because of the desire to have as many people as possible be able to hear the topic. The treatment of myocardial infarction has really evolved over the past few years, especially in the pre-hospital setting. We've gone from just transporting chest pain patients to being able to pre-alert the hospital with a 12-lead ECG, either by transmitting it or at least interpreting it and alerting the hospital that we have a STEMI. By doing so, time and muscle are saved. Somewhere between 15 and 30 minutes of time is saved in most systems if you can pre-alert the heart hospital that you're coming with an ST elevation MI. The cath team gets ready, the patients get into the lab quicker, and you save muscle and obviously improve morbidity and mortality. One of the things that I've had trouble with is trying to figure out how I can remember things, and so based on some learning theory, tried to remember things in groups of 5, and gotten a reputation for teaching in groups of 5, like 5 causes of altered mental status, 5 causes of seizures, the 5 things you do every time, every patient. And so O2, O2 SAT, IV access, ECG 12 lead when you're approaching a patient with chest pain. There are 5 causes of altered mental status: vital sign abnormality, toxic metabolic, structural causes, infectious causes, and then for altered mental status, psychiatric. You can use the same 5 for status seizures if you change psychiatric to idiopathic epilepsy. I think those who can do and those who can't teach, and those who can't teach that well teach emergency medicine. And so that was my career choice. And I've been lucky enough to have that opportunity and try to instill my pathology in the people I work with. So I think if you ask many of the men and women I work with, either in the hospital or in EMS, for 5 causes of certain things, they can do it. Certainly our people can tell you that there are 5 ways to diagnose an acute myocardial infarction. Anyone can tell you ST elevation up or reciprocal changes down or Q waves. But people that know ECGs or know 5 also know you can compare it to the old ECG or get a new one. And those are the 5 ways. I have the privilege of being one of the Eagles, and that's a medical directors group that Paul Pepe in Dallas started. And what he did is he began to gather the EMS medical directors of the larger U.S. cities, and we now cover more than 50 to 60 million covered lives. And we have members that are in the FBI, Secret Service, members in Canada. We now have Fiona Moore, who's in London. But we as a group get together once a year, but on the internet, it's almost every other day we're able to ask each other questions, and in minutes to 24 hours, hear from 30 or 40 fellow Eagles about different things, different controversies, or hey, what are you doing with this? Are you using intranasal Versed? Are you transporting only to heart hospitals? It really allows us to talk quickly to each other. One of the beauties of the Eagles is that because many of us are involved in different organizations, when we meet, we're also hearing from both officers and often the president of the National Association of EMS Physicians. We're hearing from people that lead the FACEP, American College of Emergency Physicians EMS Committee. It's really a great and vibrant organization. What we did this year was we did a Eagles-like lightning round, what's going on with the Eagles, and we talked about things we'd discussed and also asked the audience for things. And we call it a lightning round because somebody asks a quick question and then each Eagle says what he or she is doing and what they've heard. It's a great way to transmit lots of information quickly. So there was a lot of discussion this year about diverting from one hospital to another, bypassing it if you had either a stroke patient or an MI patient, ST elevation MI patient. And we universally agreed, and among the Eagles universally agree, that as long as it's a reasonable driving distance, it's much more important to get to the right hospital rather than the closest hospital. If you're having a stroke, you want to go to a stroke center that's prepared to give you thrombolytics, and not in 3 hours, but in up to 4.5 hours. And many of the stroke centers are prepared to also go into the lab for stenting procedures or experimental therapy. Similarly, for heart attacks, if you're having an ST elevation MI, you want to go to a center that from the time the EMS service alerts you to the time you're in the lab is under 60 to 90 minutes. We used to talk 90 minutes door to balloon. Now we're talking 90 minutes E2B rather than D2B. From emergency access, from the time that paramedic's by your side till the balloon is open in the cath lab in under 90 minutes.